Hi, everyone. Good morning or afternoon, depending on where you are joining us from. My name is Ariel Kramer, and today we're happy to present the finalist spotlight for Provider Diagnostics. We are the Digital Health Hub Foundation, a digital health accelerator at the Worldwide Center for Healthcare Innovation. We are in our sixth year. Awards program is dedicated to identifying the most transformative, disruptive, and innovative companies shaping the future of healthcare. This year, out of over 1,500 applicants, 300 were named quarterfinalists, and we've narrowed it down to 150 exceptional finalists. And today, we're proud to present our 4 best in class and 8 rising star finalists in our home provider diagnostic category, leaders and companies who are truly revolutionizing the industry. As a reminder, this session will be fast paced, and we will have 12 companies to present. So this is only a small taste of what these companies already have shared as part of their application. Next, we have Paul Grand, CEO of MedTech Innovator.
All right. Hello, everybody. I'm Paul Grand. I'm the CEO of MedTech Innovator. For those of you who aren't familiar with us, MedTech Innovator is the world's largest healthcare accelerator. We focus on finding the world's most promising innovations. Doesn't matter where they're based, doesn't matter what field they're in, as long as it's healthcare, and as long as it's either digital device, diagnostic, or life science tools. It's a fit for us. We want to make sure these technologies actually reach patients and with the proper value to actually be purchasable so that they can achieve their mission of improving health. So very happy to be here today and to be part of the Digital Health Hub Foundation's awards. We've been doing this since the very beginning and happy to be here.
To set the stage of what's happening in this space, so I will hand it over to you, Amberly.
Perfect. Thank you, Ariel. Hi, everyone. Good morning or good afternoon. It's great to be with you all today, and congratulations to our finalist. My name is Amberly Dietz. I'm from Avia. We are a digital health advisory firm partnering with about 50 health systems across the country on their digital health strategies. And so today we're going to talk about some of the market trends as we think about the provider diagnostic space, really thinking about that fusion of digital and biological, especially as we have seen a lot more data generated from a health system perspective. And so really making sure that we can make sense of all of this from a diagnostic perspective and also be able to tailor the treatment plans from a provider perspective as well for patients in hope to empower our teams, but also making sure that provide outcomes can also improve as well. And so we'll head to the next slide. And so as we think about the global provider diagnostics market, we know that it is growing annually at a rate of 8 to 10%, currently valued at $117 billion. And so really thinking about what this means for providers that are providing care to patients today, but also thinking about how this space is poised for growth in the coming years. And so really thinking about provider diagnostics and how it can enable more accurate, predictive clinical decision support, really being able to provide that right care at the right time. And you'll hear a lot from our panelists today about how they're doing that today for health systems and providers, and really making sense of the data and what it means for patients at the point of care and their care plans as well. And then really making sure that, as the advancements with technology, making sure that as you are developing these different technologies, making sure that you're leveraging providers as champions throughout, so that way these workflows can really enhance at the point of care decision making as well. And so a lot of great innovation to come, and excited to hear more about about the different technologies from our panelists today and how they're leveraging AI and enhanced clinical decision support tools, but also leveraging that real-time data for at the point of care. And so we'll head to the next slide. And so as I wrap up here, you'll see a bunch of different opportunities for digital along the care journey, but really a lot of our panelists today are going to be focusing on that AI screening and diagnosis as part of the care team and the care journey as well. And so we'll head to the next slide. And so these are just some examples of different capabilities that you'll see today, really kind of honing in on that second category for AI screening and diagnosis, really making sure that we can provide better care to our patients, but also help our providers who are at the point of care for those AI-powered diagnostics. And so before I hand it over for the great discussion today, I did want to mention from an Avia perspective, we have launched Avia Marketplace. And so this is where health system leaders, we have about 70% of health systems across the country who come to the Avia Marketplace to really look at different solutions in the market. Who have they partnered with? What are the different capabilities? And so as a gift to the panelists that are here today, we have launched our buyer intelligence to really kind of help from a sales perspective as well. And so really seeing, as we explore this topic further and the different technologies, the impacts on clinical workflows and the possibilities, but wanted to mention that we do have the buyer intelligence as well for all of the solution companies that are in this space. And so for those that are here, you should have received an email from Melissa or Ariel as well. And so if you have any questions, definitely let us know. And so we'll head to the next slide as we wrap up here. And so the buyer intelligence can really help from your sales cycle and target high value accounts and also kind of turbocharge your sales pipeline. And it really kind of highlights the 70% of those health systems who are looking at the different companies, who's looking at you and your competitors as well. So with that, thank you so much. I will hand it back over to Paul.
So let's go ahead and get into our introductions. We've got 12 terrific companies that we're going to be talking to today. Our goal is to make sure that you, whether you're just somebody watching or one of the judges who are evaluating companies, has a chance to get to know these companies a little more. So we're going to give you 60 seconds each to run through yourself, who you are, a little bit about your company and opportunity. And again, maybe your superpower if you want to do that, but 1 minute each. So we'll go through each company and then we'll get into some detailed questions for each company. So I'm going to call out companies and in a minute and do that. But I just see also we have Chrissy Farr here as well. I want to make sure she has a chance to introduce herself. So Chrissy, if you want to unmute and introduce yourself too.
Hi, everyone. Nice to see you all here. Chrissy Farr, longtime journalist, turned VC, and now working at Manap doing a bunch of advisory work in addition to running my newsletter, Second Opinion. So excited to be here and learn more about all of you. Thanks, Paul.
Absolutely. And if you're not reading Second Opinion, I suggest you do. It's a great read. All right, so let's go ahead and do some very quick introductions. Again, watch that clock, 60 seconds each. I'm just going to go off the order over here that I see in the panelists. So I'll start with Dr. Leon Anajar from Flagler Health.
Hey, everybody, this is awesome. My name is Leon Anajar. I'm the Chief Medical Officer and co-founder of Flagler Health. We do a lot, but our marquee product is an AI operating system for musculoskeletal clinics that automatically triages patients to the right provider and then monitors the patient's health after they leave the office. We started in 2022. We're currently in 21 states. We work with thousands of providers, and we've helped treat a little over 10,000 patients at this point. We're super excited to be included in this and look forward to the discussion.
Terrific. Next up, we've got Frank Chang from Caristo Diagnostics.
Hello, everyone. I'm Frank. So at Caristo, our CareHeart solution identifies coronary inflammation, a very important clinical marker that used to be invisible, but now with our technology is not only visible, but fully quantifiable. We do this by analyzing routine cardiac CT scans, and this coronary inflammation is now proven to have strong correlation to both fatal as well as non-fatal cardiac events for years down the road. So it's great to be here.
Welcome. All right, next, Paul Prano from INUC.
Thank you, Paul. Hello, everybody. I'm Paul from INUC, Chief Commercial Officer. At INUC, we are developing and have an FDA-cleared AI software for the autonomous detection of diabetic retinopathy. And we are right now currently developing a sort of a platform for the future at the point of care for large chronic diseases that affect the population at large beyond just diabetic retinopathy. And just in short, diabetic patients right now throughout the globe, about half of them are not getting screened. It's the leading cause of blindness in working age adults. We have the opportunity at the point of care to use AI software to analyze fundus images or retina images in 30 seconds and get these patients the treatment and the care that they need. So it's a pleasure and an honor to share this panel with everybody, and thank you for having us.
Thank you. Sandeep Dave from Data Driven Biosciences.
Hi, I'm Sandeep Dave, founder and CEO of Data Driven Bioscience. I'm an oncologist by training, and we've developed a new test for diagnosing cancer. So this is a really critical problem, as almost all of our lives are touched by cancer, either directly, as many of us are destined to develop it as a function of aging, and or as a function of having a loved one affected by cancer. And that journey of a cancer patient starts with a biopsy, and that biopsy that is taken as a piece of the tumor is subjected to a number of different sequential tests that can take about 2 to 3 weeks and about $10,000 to $15,000 to perform. That wait of 2 to 3 weeks can be agony. I know this when my mom went through her diagnosis of breast cancer. I know this as an oncologist, where we often spend weeks waiting for a patient to get a diagnosis, while still waiting to before we can start treating them. So we've developed a combination of a genomic test and AI software that was based on over 100,000 patients' data that allows us to automate the entire process. So we can take this process that takes over 2 to 3 weeks and $10,000 to $15,000 and enable next day diagnosis for about $1,000. So basically 10x faster and 10x cheaper.
Terrific. Thanks, Sandeep. Next up, Adam Dakin, Keraton.
Right. So thanks so much. Good to see you, Paul. Thanks for inviting us to participate. Really delighted to have been selected. So Adam Dakin, President, CEO of Keraton. The problem we solve at Keraton is addressing the safety and the challenging workflows associated with inpatient feeding, particularly with formulas and expressed human milk. So think of us like medication barcode scanning. No hospital would give medication without barcode scanning, right? It's just basic fundamental safety, making sure the right patient gets the right medication and you document it appropriately. We literally do the exact same thing for inpatient enteral or human feeding, tube feeding, enteral tube feeding. We believe that no patient should be fed without barcode scanning because it's very easy to give the wrong patient the wrong feed. Turns out these feeding orders, particularly our target is intensive care units. These feeding orders are insanely complex. You could have 15 to 20 variables in a single feeding order. So it's very easily to make a mistake when the nurses who are typically administering the feed are trying to prepare those feeds. So what we've learned in managing over 1.7 million inpatient feeds at this point is that 2% of the time there is an error that is potentially harmful to the patient. So we intervene and alert the provider before that mistake happens, helping them achieve zero harm and avoiding mistakes that could potentially be very harmful. Because you imagine, for example, in the neonatal ICU, if you give the wrong milk to the wrong kid, the clinical consequences are very significant and actually include death. So that is the Keraton platform. I'm super excited to be here and appreciate the opportunity.
Thanks, Adam. Next up, Amir Hassan from Ultromix.
Hey everyone, good to meet you. Amir from Ultromix. I'm the Chief Operating Officer for Ultromix. We're a spin out from Oxford University. We spun out around 7 years ago. We're the world's only AI diagnostic in echo imaging. So echocardiogram is ultrasound imaging of the heart. And we built an AI-based diagnostic for heart failure. So heart failure, as many of you probably know, is kind of one of the biggest kind of cost drivers for hospitalization across the US. I think it's almost $50 billion now spent on heart failure hospitalizations. One of the issues in heart failure diagnosis is it's quite easy to see the heart pumping and see how well blood is actually pumping out of the heart. But one of the really complex things to look at is how well is it actually filling up with blood. And this is something that's actually typically very difficult to see from an echocardiogram. And in fact, 64% of patients with this diastolic dysfunction or heart failure with preserved ejection fraction are underdiagnosed. They're actually going home. They're the frequent flyer patients that keep coming back into the hospital and costing the health system a lot of money. So we built a diagnostic that can just take a single apical view of the heart, a 30-second clip, put it through a diagnostic and produce a diagnostic report within minutes. And it's delivered in a cloud-based solution at the hospital. Good to meet you all.
Thank you, Amir. All right, next, David Stoffel from Rapid AI.
All right. Thank you, Paul. And it's great to be on a panel like this and to see so many innovative companies. So congrats to everybody. This is a lot of fun to see and hear about everyone's things. Rapid AI is a AI-aided imaging diagnostic company. Provide that diagnostic. We also lead the care coordination thereafter, and also track those changes and track the patient management over time. We started in stroke. It's obviously a very acute condition. We migrated across the brain into more chronic conditions such as aneurysm. We've done hemorrhagic stroke. We're moving down the body as well into other conditions like pulmonary embolism, AAA, and other variety of other disease states. We're in over 2,200 hospitals today and over 100 countries. So again, excited to be here and learn about everybody on the panel.
Terrific. Thank you. Next up, Dimitri Giannakopoulos, AI Doc.
Yes, Dimitri Giannakopoulos, the Chief Transformation Officer at ADOC. It's a pleasure to be here today. Thank you for the opportunity. We started in the diagnostic imaging world. We're still very much there with 17 FDA-cleared Class 2 medical devices, as well as a half dozen partners integrated into our AI operating system. Our AI operating system is used at thousands of health systems across the globe, and that's all since our founding in 2016, which was really a perfect time to start in this space because we were really able to capitalize on the most recent advancements in AI, convolutional neural networks that led to all these imaging-based capabilities, but also things like natural language processing going through a refresh. If I think about our superpower, it's twofold. First, we recognize that an AI algorithm by itself is technology. So we leverage AI to identify where we should apply the AI. Looking at the raw images, for example, to identify, hey, it's unexpected that this has the heart in it, but it does. So let's look at the heart. And then activate the right care team from there based on what we see. And then finally, on that activation side, actually integrating into the clinical flows, making sure that this technology that's great and can provide all this data can actually be used as part of that patient's journey through the institution to really facilitate their care and get them to the right doctor at the right time, in the right way.
Terrific. Thanks, Dimitri. All right, John Emil Kenny from Flowsonics.
Hi, thank you so much for inviting me. It's an honor to be a part of this. I'm John. I'm the co-founder and chief medical officer of Flowsonics Medical. My background is pulmonary and critical care medicine. What we've done at Flowsonics Medical is we've developed the world's first wireless wearable Doppler ultrasound system. I think it's a very elegant solution because it looks at both the right heart and the left heart simultaneously down through the neck. And our superpower right now is helping sepsis resuscitation, giving the right amount of intravenous fluids in sepsis. It has a bit of a Goldilocks principle. You don't want to give too little, and you don't want to give too much because there's complications from both. So we've been used on just about 2,000 patients now to help gauge sepsis resuscitation in that regard. Because there's a very high incidence of both acute systolic and diastolic cardiac dysfunction and sepsis. We've also accumulated a database of many millions of cardiac cycles that's going to help us fingerprint and phenotype cardiac pathologies moving forward. We hope to help prognosticate early sepsis and then beyond the inpatient realm into the outpatient realm using AI-enhanced algorithms.
Terrific. Thank you, John. All right. Next up, Juan Jimenez from AcuCardia.
Good morning. Good morning. Thank you, Paul. And thank you, everyone, for having me. I'm Juan Jimenez, co-founder and CEO of AcuCardia. In AcuCardia, we are leveraging ECG as a broad biomarkers with applications in cardiology and beyond. We are leveraging the 100 million patients screened with ECGs every year in America. And our superpower is to deliver this capability with an FDA-cleared solution to the 46% of counties in America without practicing cardiologists and 10% of counties with just one cardiologist. We're bringing this capability of world-class cardiac care to every zip code in America.
Terrific. Thanks, Juan. All right, Pelu Tran, Ferrum Health.
Thank you, Paul. It's incredibly clear that diagnostics means AI today, and it's an honor to be alongside all of these incredibly powerful technologies. Ferrum Health is making it effortless for hospitals to adopt AI, and we believe that that is the single thing preventing the companies on this call from reaching hundreds of times more impact than they have currently. So hospitals' adoption of AI is bottlenecked by data security, model performance, market fragmentation, and we provide a single platform for hospital systems to be able to deploy, monitor, integrate, and update their third-party AI solutions. We have over 70 AI vendors that we have worked with across over 250 sites of care in the US, and across the 2.5 million patients that we've helped hospitals deploy AI onto, we have found over 200,000 additional disease diagnosis for the patient populations. So AI is going to save millions of patients over the coming years. The reason why it's not already is because hospitals are struggling to adopt the technology, and Ferrum makes it effortless for them to do so for all of us on this call.
Thank you. I hope AI is going to save millions. And Sushi Saria, Bayesian Health. Oop, you're muted, Sushi.
Lovely to meet everybody, and especially John Emil. We should follow up because of your interest in sepsis. I lost my nephew to sepsis. I'm the founder CEO of Bayesian Health. A little bit about my background: I worked in AI for a little over 20 years in research at Hopkins as a professor across AI and health, advancing the fundamental technology, translation, and also serve as a SME on the AI regulatory side to several of the federal agencies, co-founded Coalition of Health AI, which works with 1,000 organizations, including the federal agencies, several of the federal agencies around AI oversight. Bayesian was a company we spun out of Hopkins with 5 years of IP, and it's essentially a multimodal clinical AI platform. So a lot of AI examples you're hearing are all across imaging. As soon as you move out of imaging to start to look at all the other kinds of data that exist, the labs, vitals, unstructured notes, not just a single modality like just text or just imaging, but the disparate, like thousands of modes of data that exist, AI for multimodal data is just sort of a whole lot harder and a whole lot more complicated. A lot of my research focused on advancing AI in those use cases. And if you can do that, you can solve really high value, hard problems that you couldn't do before. As an example, in 2022, we published these trials, 3 manuscripts that came out on the cover of Nature Medicine. In sepsis, which is the leading cause of death in hospitals, open problem in the field. So many people have tried, so many people have attempted but haven't made it very far. We showed effectively 5.7, like 10x better performance than anything else that exists today using our platform. And effectively what we showed in these manuscripts was 5.7-hour earlier detection than best physicians at Hopkins across 750,000 patients, a massive trial. We did this across academic and community sites. So effectively, over 2.5 years, so pretty massive trial. So one, the ability to detect. The second set of things we showed was 90% provider adoption, because it's one thing to detect. The second is this provider is going to adopt. And so in these trials, again, very 2.5 years sustained adoption by 4,400 clinicians using the platform. And then, of course, if you have earlier detection and adoption, then you're going to see outcomes. And we showed nearly 20% reductions in mortality. These were one of the earliest and biggest and one-of-a-kind results in terms of the adoption data, but also the mortality data. And from there, we've gone now and we're implemented at places like Northwell and Cleveland, and are partnering with systems like Mayo and Memorial Care and ThedaCare and LifeBridge, and just as and are again replicating. So, for instance, at Cleveland, within a month, we went from implementing to 92% physician adoption, and are scaling enterprise-wide across all US hospitals. I talked a lot about sepsis, but really Bayesian's platform tackles, there are about 20 to 30 such odd conditions where effectively the ability to detect early, facilitate diagnosis, treat and manage patients gets to better clinical outcome and financial outcome, like deterioration, pressure ulcers. So we're working on a range of conditions with our health system partners.
Terrific. All right. Great introductions, everyone. You guys covered a lot. I want to make sure we get into some details here that help some of the judges in their final determination. So I'm going to start with our best in class companies. So these are 4 companies that are competing for best in class. meaning that you're already you're the more mature companies amongst the group here. Although a lot of the rising stars are pretty mature as well. So I don't want to take anything away from the rising stars. It's just in terms of company longevity, in some cases, the best in class are a little more mature. So, we expect a lot from you. And we also have a lot that we've seen in the market that isn't working or that is failing or isn't managing to succeed. And we want to make sure you guys do succeed. So I want to make sure you get your message out in this next segment. And we only have time for probably literally one question for each of you based on the amount of time we have in total. So I'm going to try and narrow this question in to one particular question. And again, some of you kind of already addressed this, but I'm just going to say this once again. So I want to make sure it's clear for everybody. And you can even repeat it if you guys need me to. But here's my question. That access to care is in many ways as important as the quality of the clinical decision support and the tools that you guys are providing. So to be successful, to be sustainable, provider diagnostics are going to have to offer value propositions that make them affordable, that it certainly offer a value proposition that is either a terrific business model or that's reimbursed, whatever that model is, whether it's enterprise, whether it's reimbursed, you've got to offer both the clinical benefit as well as an economic benefit if you're going to be sustainable. So what I'd like you to do is explain that to our judges, summarize the key message that you would tell in this very short period of time you have of your clinical and economic value propositions. And make sure you tell us if you're reimbursed or if you're just, an enterprise sale that's going to just fit into the overall economics, and explain that business model. So it's really ultimately business model that we're kind of going after here, as well as the benefits. So each of you are going to have, no more than 2 minutes to answer this. So do your best to do that. And I may do a follow-up if you give me a shorter answer, which is just fine. So we're going to start off with Rapid AI and David.
All right, sure. What you really articulated is very close to Rapid's North Star. And our vision is that any patient showing up at any hospital, whether it's the highest academic center in the middle of a city or in the most rural center in Alaska, that patient is going to get the best possible care and the best possible clinical support and the best possible decision-making. And in order to do that, you really have to recognize that not all hospitals are created equal. So in other words, that hospital in rural Alaska is going to have different imaging capabilities than that academic center. And that's really where we've developed algorithms and technology where our AI can work with non-contrast CTs, where most hospitals have it, very simple, to the most complex advanced imaging, including MR. And that way, we've really focused on enabling every hospital, no matter what the status, no matter where the location, can be connected to AI. And when you're connected to AI and you're shared immediately within PACS and all the information is shared within mobile, you're connected to the interventionalist, you're connected to those experts so they can support those patients in those rural spokes to see if there was an immediate transfer that's needed or an intervention that's required. And really what you do there is you're changing clinical decision-making. You're enabling patients who wouldn't otherwise get an intervention or a transfer to get that faster and to get that better care. And that, not ironically, works better for the hospital system as well. So the hospital now, instead of calling, they're able to look and see the images, so they make decisions faster. So we take friction out of the system, enabling people to do their job faster. And by getting those incremental procedures, the hospital system is benefiting as well from an economic standpoint. The spoke also benefits because sometimes the transfer isn't needed. So they can keep that patient in their four walls, close to their family, keep that DRG there, and keep the people satisfied by not having their family move around so much. So from a total cost of care standpoint, we have a huge return for the hospitals. We are a SaaS subscription model. It's yearly. But we do actually, because we actually have focused on not just triage, but also quantification, characterization, tracking over time, that requires heavier FDA clearances. So instead of just what's called CAD-T, which are very simple, we're also in the CAD-X category, which is diagnostic. So that actually qualifies for reimbursement for some of our modules such as aspects, which is an aspect score for stroke, hyperdensity, which is a quantification for volumetric hemorrhages for obviously trauma and hemorrhagic situations. So we always sell on the cost of care, the total cost of care, and the efficiencies that we bring. Hospitals buy it because of that, but we also do have reimbursements because of our dedication towards supporting decision-making with heavier requirements from the FDA. And we try to fulfill those because we think that's the best way we can support clinical decision-making.
All right, David, great answer. Understand the value prop. So thank you very much. In the interest of time, I'm going to move on to Dimitri from AI Doc. So again, same question for you. Really make sure we understand the clinical benefit, whether it's PE or whatever it is that you guys are helping to improve with clinical decision support, but also the economic model that's going to make you sustainable.
Excellent. So as a foundation element of our approach, you can look at our licensing style. It's an enterprise license. We don't just go and install at the tertiary or quaternary medical center, hoping that those patients will be the ones that benefit from AI, but instead approach the enterprise. And how can this be leveraged across the entire enterprise? Present in the community, it's as though you present at the University Medical Center. There really shouldn't be that level of variation, and we think it's extremely important to apply AI using that same methodology. We are a SaaS license, so an annual fee, not under a reimbursed model. We do have some applications that could qualify, but as it stands, not in that route. And I'd say from an outcomes perspective, if you look at some of our solutions, one good example is the pulmonary embolism response team solution. It leverages literally 4 different AI applications to identify, is this a patient that should be brought to the attention, have a team activated to care for them. And PEs are patients that are oftentimes labeled tweeners. Like they aren't really, the most acute, they're not the least acute. They're in that middle spot. So they don't always get the highest attention. By having those types of solutions implemented, Methodist Healthcare in San Antonio, HCA joint venture, found a 55% reduction in their ICU length of stay. And that's device agnostic because there's also a lot of new devices coming around. Cedars-Sinai did a similar analysis. They found 23%. They went so far as to value the cost savings of that to $504,000 for those patients that are receiving advanced procedures. The other key element is really how does this fit into the long-term management of these patients as well? So Yale, we've been partnering with their vascular surgery team, and they've shown that they've been able to decrease the time to repair for patients with 5-centimeter or greater aneurysms by 75%. Taking it down from 278 days down to 58 days. So, really driving fast care and impactful care. Ultimately, that results in more procedures. That results in less complicated, patients from both treatment and outcome side. So really important to look at that holistic benefit and identify how it actually fits in the workflow, meet with the med exec committee, establish scope of care, like all those boring things that ultimately will hinder impact of these types of solutions if they're not done. And then work with the partners to quantify the value.
Terrific, Dimitri. That's a good way of explaining it. And I know you've got a lot of different things you guys do. So that was a good, concise one. Thank you. And really, by the way, guys, again, for these next ones, and we're going to keep going with the same question, but again, think of it as like, you're going into, you got this 1 or 2 minutes with an executive at one of these institutions, and you got to just convince them as to why they want to have a longer meeting with you, or set up a meeting after you meet them briefly. So let's keep going. Next up, we've got Flowsonics Medical. John, so your technology, I know you talked about sepsis as being one of your first things you guys are focused on. So again, explain to us, again, sustainably, economically, et cetera, how is this going to work in the long term to provide the value that's going to let you guys succeed?
Yeah, thanks again for the invite. We've been on just about 2,000 patients now, and I think what really comes to mind is just a recent story of resuscitation that where our device was used to help facilitate the best efficient, the best care, the most cost efficient care. And it was a very young man in his early 40s that sustained a traumatic brain injury was completely bedbound, in and out of the ICU recurrently, recurrent bed sores, recurrent infections, recurrent pneumonias, had a feeding tube, was chronically mechanically ventilated through tracheostomy. And he showed up again in the emergency department with signs of brewing sepsis again. It was severe sepsis. So he had some organ dysfunction. He had a severe infection. It was thought to be a pneumonia. But he also had really known poor cardiac function. He just had a history of very bad cardiac disease. He had known ejection fraction of less than 20%, and normal's 60% or above. And his blood pressure was low, but the physicians in the emergency room were just really reluctant to give any intravenous fluids because they knew how bad his heart was, and they didn't want his lungs to fill with water. They didn't want him to have a prolonged course on mechanical ventilation. His family didn't want him going back to the ICU because he's been in and out of the ICU recurrently. It's a strain on the family. So the nurse put our device on, and in less than 2 minutes, they knew that his right heart looked good. They knew that his left heart looked good. They did something called a passive leg raise. They saw that his heart responded appropriately would respond appropriately to intravenous fluid. So they gave him intravenous fluids, even though kind of all of his medical history pointed to giving no fluids. They were ready to put central lines in them. They were ready to start him on inotropes. The cardiologist was there, but what our device did was it gave the emergency room physicians confidence to resuscitate that patient with intravenous fluids. He didn't even have to go to step down. They saved him the central line. They saved him the inotropes, the vasopressors. They saved him an ICU stay. So severe sepsis with mechanical ventilation for more than 96 hours, the hospital gets $42,000, and they get that amount of money to distribute their care. So the price of our device, they were able to claim that DRG and deliver care at a fraction of the cost. So there's a very strong financial model for allowing hospitals to deliver efficient care, save money out of the DRG. But I mean, honestly, most importantly, it's just keeping that guy out of the ICU that didn't need to go to the ICU is the real value prop for our device.
All right. Well, great value prop, both clinically and it sounds like economically. So thank you, John. All right, let's move on to Ultromics. So Ross, same question for you. Heart failure, AI-powered HFpEF detection is certainly something that makes a lot of sense, but convince us economically and clinically that you're the solution for this.
Yeah, I mean, I think it's fairly easy to convince someone because these patients are the frequent flyer patients. They come to the emergency room, they're short of breath. They often go through an echo workup, an ECG, and they get sent home. They think, well, you're just getting old. Maybe change your diet, maybe exercise a bit more. And they're the frequent flyers. They come back and eventually they're hospitalized. And a heart failure hospitalization costs $20,000 in the US. And for every hospital institution, this is a huge expense, and they don't make money here. They just lose money on these patients. So by using AI, we're able to take the first echo and we identify just off a single apical 4-chamber clip. So we don't need the full echo, we just need a single 30 frames, kind of one heartbeat. And just off that, which makes it very accessible, very usable by anyone, just off that, we can diagnose heart failure. So that lends itself really well to being much more scalable. So the advent of handheld diagnostics, butterfly probes, and people walking around with specific, very small ultrasound machines to find these patients. But on the economic side, it's not just about saving the cost of hospitalizations. We have 2 reimbursement codes for the AI technology. We have both an inpatient NTAP code and a category 3 CPT code. So from a financial standpoint, the provider can actually get paid for doing the diagnostic. They can identify the patient. They can stop them being hospitalized and then get them on treatment to make sure they don't end up in the hospital again and again. So they stop being a frequent flyer. So just purely from the economics, the story makes sense. But just from the patient standpoint, getting them diagnosed earlier in the pathway means they can have much better survivability, lower mortality, much lower chance of repeat hospitalization. So early identification early in the pathway is the critical piece. And the last piece is ultrasound. There's no radiation, there's no expensive CT scans. It's very scalable, very mobile, which means that it can drive access to care in the community. This can be done in primary care. And that's the future of heart failure detection.
Thanks for sharing the future for us. We appreciate it. All right, so those are our 4 rising stars. Great job, guys. We're not, excuse me, our 4 best-in-class companies. So terrific job, guys. We're going to move on to our rising stars. So as I said before, these companies, theoretically are a little bit earlier, but as you heard, I think in the introductions, these companies are actually in many cases pretty mature. Some seeing thousands of patients already. Training models on incredible data sets. So hopefully you've heard that first section. I want to talk in this section. We're only going to have again about 1 question per company in the time that we have left. There's 8 of you, and if you talk for 2 minutes, that's all we have left. So I'm going to probably just give you 1 question unless you answer really quickly, and then I'll give you another one. But the question I want to tackle here is similar to the first one. So again, we're really talking about value proposition, but similar to the way I think John did a nice job of this earlier, is giving an anecdote. So maybe give us, so we can both understand the value prop from a larger perspective. Maybe as you talk about percentage of reduction or whatever it is you're going to talk about, but also give us a good anecdote so we can really understand what the intervention will look like. Or what it could look like on the provider side if they have your technology. What is, give us an example if you already hopefully have one from your experience thus far. We're going to go on now with our rising stars, 2 minutes each at most, guys. Again, tell us about the value proposition and include an anecdote in particular about your technology, if you can, that explains to us how it's gonna change care, and again, that hopefully will be sustainable for your company and improving outcomes and economics. So start with Keraton and Adam Dakin.
Sure. So just as a reminder, right, we're an inpatient feeding management and nutrition platform. So I'm reminded that when I lived in California, there was a chain of pie restaurants, and they used to advertise, "Come for the food and stay for the pie." So we're come for the safety and stay for the workflow. What we do is dramatically improve the safety of feeds. Our target core markets are pediatric, neonatal, ICUs, where I can tell you there isn't a NICU or PICU on the planet that hasn't fed the wrong milk or the wrong formula to the wrong kid at some time. And it happens way more routinely than it should. It's harmful to the kid. It's harmful to the reputation of the hospital. It's an event. It's a reportable event. But yet the way most institutions handle this today is with handwritten labels. A typical kids hospital will manage 20,000 bottles a year. Can you imagine the inventory and logistical nightmare? Some are frozen, some are in the fridge, some are in the parent's home. They could be at the loading dock. It's virtually impossible to keep track of this inventory using handwritten labels and spreadsheets or logs, but that's how it's done in most hospitals today, right? Imagine, what could possibly go wrong? So just like medication management, there is literally no way to keep track of the inventory to make sure you're giving the right feed to the right kid without our platform. So our platform is a mission critical SaaS platform, right? We embed inside the EHR, and we intervene on the safety side before the error gets made. So literally, if a provider stays within our platform, they will not make any errors. If you're a really good ICU, your error rate's around 2%. We have seen institutions with much higher error rates than that. So that's the safety piece. But then the reason customers love us is because we make their workflows so much better. They don't have to do handwritten labels. It's called 2RN checks. Anytime you feed a kid, you need to call another nurse over and say, "Hey, this is the right milk, right feed for the right kid, right? You agree?" That could take 5 or 10 minutes in and of itself. Then it all has to get charted and documented. The other piece that we do that's really important on the access side is we enable providers and families to communicate. We create a direct pipeline between them. So that's the value. And as one of our customers recently said, if you took away, this was one of the nursing leaders at one of our customers, she said, if you took away keratin, I would retire.
All right, that's a great way of summarizing it. And again, for everybody else listening here, the rest of you haven't gone yet. You can again give an anecdote. You can give a quote like that from a provider who's used the technology to help reinforce the point. Make sure you give us the overall value proposition as well as you're explaining it. So let's move on then to INUC. Paul.
Thank you, Paul. So I'd like to just have sort of everybody imagine the patient journey for a moment. If you think about patients right now, where we are FDA cleared is for patients that are diabetic, and these patients are recommended to get their annual eye exams once a year. Again, it is the leading cause of blindness in working age adults. It is a global problem, not just a U.S. problem. And essentially, the issue you have is patients are getting diagnosed with diabetes in their primary care clinics. They're being given referral to go to an eye care specialist to go then and get their screening for their retina screening for diabetic retinopathy. Half of these patients are not making it to the eye care specialist. We could have a whole nother panel on why they're not making it, but they're not making it. And so if we have the opportunity to take this fully autonomous software technology, put it at the point of care where the exam can take about 5 minutes or less, we can get an AI diagnostic result within 30 seconds. And then we can give you a level of detection where it's just a more than mild detection, or it actually can tell you if it's vision threatening, where then you can prioritize these patients for follow-up treatment, whether they need to get to a retina specialist because it's critically urgent, or maybe they just need to go for eye care follow-up within a couple of months. And so we can get down to that level of detail. And so, as an anecdote, we have started to build case studies, and we've done one recently through our connection and relationship with the University of Nebraska, where we had one of their clinics, and in 1 year, they saw almost a 40% increase in compliance with their diabetic eye exams. And so these patients now are able to stay there on the spot and get this screening, and then follow-up treatment can then follow. And so we are really in the business of eliminating preventable blindness. And when you think about the value proposition, when you couple that clinical benefit, we have a very accurate and safe technology. It's been proven in over 200,000 patients as it's been studied. But when you think about the economic value proposition as it's layered on with the clinical value proposition, from an economics perspective, value-based care is only becoming more and more prevalent in our healthcare system. And a lot of these clinics and primary care offices are incentivized from HEDIS and from MIPS and quality care scores for them. And diabetic eye exams is one of the ones that they struggle with the most from a primary care clinic perspective. So there's economic incentive for them to hit these value care gaps, along with a level 1, category 1 CPT code as well, that also covers the technology. So from an economic perspective, it's viable. From a clinical perspective, it's safe and accurate, and it gets them at the point of care, which gets them the treatment. And hopefully we can eliminate preventable blindness because there are treatments for these patients. So hopefully that sums it up for you.
Yeah, no, you did a really nice job of that, Paul. Good job. All right, let's move on then to data-driven bioscience. So, I know sequencing is becoming an essential tool, not always affordable, and I know you guys have a good solution for that. So Sandeep, tell us about it.
Yeah, so a key starting point for our company was to make genomic sequencing ubiquitous. If you think about the technology itself on a per gene level or per marker level, it is actually the cheapest technology out there. It is made expensive by all the complexity that surrounds it. And so we can attack that problem of complexity from 2 angles. One is to create a simpler genomic test that allows people to do DNA and RNA sequencing in one go, that allows you to kind of use a sequencer that most hospitals have but underutilize. And then we had to attack the other end of the problem through software, so that once you have the sequencing data, you know what it actually means in terms of the diagnostic test. So we had to render what pathologists and clinicians are used to seeing, but in terms of genomics. So we use genomics to render tests that they're already expecting to see. And so this has the advantage of being able to run on existing rails of hospital processes and reimbursement systems. So we're able to build on CPT codes that use genomic tests and have all this extra added value that can replace multiple different workflows in the hospital. And so the value of the hospital is that they don't need to maintain the ability to do 15 different workflows. They can combine a lot of this into a single workflow, and that makes reimbursement easier. We've also taken the strategy of engaging early with the FDA so that we know that our test is on a path to FDA approval from the get-go. That also enables wider adoption. When I was training as an oncologist, I was one of the very first patients I saw was a patient with Burkitt lymphoma, which is a very distinctive appearing cancer. These cancers have a doubling time of as little as 8 hours. So you see a patient in the morning and you see them in the evening, and the tumor, if it is visible under the skin, has visibly grown. It is also an unusual cancer in that it is curable, in that if you diagnose these patients correctly and treat them appropriately with high-dose chemotherapy, something like 80 or 90% of these patients will be cured, right? Which is unusual among cancers, even when the cancer is spread. But the catch is it has to be diagnosed correctly, and the misclassification and misdiagnosis rates for this tumor are as high as 50%, even in clinical trials. And so we are able to develop algorithms that trained on large numbers of these patients and report the likelihood that any given patient has this particular diagnosis, or hundreds of other cancer types that we were trained on. And when we went live at Indiana University Hospital, which was one of our first clients, in the very first week, they had a patient that our algorithm reported as Burkitt lymphoma being the most likely diagnosis. And I was able to talk to them. And actually, that patient was referred from a community hospital where they were given an entirely different diagnosis. Right? It was really fun and gratifying to see the whole thing come a full circle. This was one of the things that inspired me as an early oncologist. And the very first time the test was run in patients after the validation process was a patient in whom the very problem that we had sought to solve was confronted and solved. So that was instant proof to the hospital and the providers that this was a test worth using in all their patients.
Thanks, Sandeep. Great story, and good to see that come full circle. So let's move on then to Caristo Diagnostics. Heart attacks. I know you guys are tackling all sorts of things, but of course, if we can better diagnose heart attacks, we can have a massive impact. So tell us, and also I know you've got approval in Europe, in the UK, Australia, right? So you've got a lot of experience. So tell us, some examples about how this technology is really going to make a huge impact in terms of value prop. Maybe you can give us a story in particular, and convince us that this is going to work in the US too.
Thank you, Paul. Thank you, Paul. Obviously, too many times, right? People have coronary artery disease, which instantly lead to death, sudden death. A little bit luckier than that is people have heart attack, but non-fatal, go into cath lab, receive stenting or bypass surgery, then hospitalized, which costs healthcare system typically $50,000 per hospitalization, right? So we're in the business of changing that paradigm and eliminate heart disease as the number one killer around the world. How do we do that? Is our AI technology can identify this key hidden risk to heart attack, which is coronary inflammation. Identify those at-risk patients early on, so medication can be used on them before they end up in cath lab or end up, obviously with a cardiac death. Right? So this is the foundation of our business and the product model: is save lives or save money as well by moving people from death or expensive treatment to early stage medication treatment, which is typically a lot more cost effective. Right. The anecdote is where we have, deployed our technology for thousands of tests here in UK market where we are based, right? So the first group of people who jump in is actually consumers and patients themselves, the people who are health conscious and also typically who are well educated, right? Celebrity, athletes, successful business people, they jump in waves well before government and the hospital systems start to realize the clinical and economic benefit, right? So we've done hundreds of tests for patients themselves. Then hospitals and now UK government start jumping to adopt this technology, which is really a little bit unusual in terms of patients and consumers instantly get the clinical benefit, instantly feel like this is cheap enough for them to take the health matters to their own hands. That really influenced media, obviously health systems, as well as even private hospital and clinics to adopt this technology as well. So which is really a unique anecdote that we have experienced.
Next up, we have Ferrum Health. Pilu, tell us, again, you understand what we're looking for here, looking for that concise answer about, give us an example of how this technology is making an impact. You can focus on BoneView or wherever you want to focus on, but tell us how it's, how the impact gives a good tangible example. And then of course, the larger value prop.
Of course. So if you talk to the vast majority of hospitals, there are a few reasons why they cannot adopt AI at scale. It's IT, it's security, it's patient safety. And so we, by helping them with the deployment of this very rapidly growing marketplace of AI solutions, Gleamer, BoneView, iCAD Breast, and many, many others, we have saved our hospitals an average of $300,000 of internal IT costs per AI solution they're deploying. We are giving them complete visibility into the clinical impact and business performance of their tools, and we're ensuring the safety of those tools for their patient populations. And so a single solution, lung cancer detection at Sutter Health, generated over $7 million per year of additional care for that organization in terms of new diagnoses of lung cancer that would not have been made without our platform. So we're saving hundreds of thousands of dollars of IT and data science costs for hospitals. We're generating millions of dollars of revenue for them. And we actually just this year passed the 1,000 lung nodule mark at Sutter. So we have found over 1,000 additional patients with significant findings for lung cancer at the organization. That's out of the 200,000 patients with new diagnoses that have been made because of our platform, enabling hospitals to deploy these AI solutions safely and effectively.
Thank you, Pello. That was great. All right, let's move on then to Flagler Health.
Thank you, Paul. Yeah, so I totally agree with the statement that you made, Paul, that unless you are providing significant value and also able to drive revenue to the practice and have incentives aligned, no one's really going to adopt your tool. We firmly believe that if you don't make it unbelievably easy for doctors, providers, hospitals, whoever's using your product to use it, they will not use it. And if you don't make it so that there's some key incentive for them to do it, they will also not do it. So it can be very easy, but doesn't generate any revenue, they're not going to do it. And it can be very hard, but if it generates a ton of revenue, they might do it, right? So what we decided to do was lean into that. We say it's beneficial to identify patients for advanced procedures, so we do that. And then to monitor these patients, there are billable CPT codes. So there's remote therapeutic monitoring codes and chronic care management codes. So we directly engage with the patients, do all the compliance, generate the note, put it all up in their EHR. All they do is give us access to an API with their electronic health record with Athena or ECW or whatever. We start generating the recommendations. We start interacting with the patient. They bill, they collect, and then we take a portion of that on the back end. So they are perfectly incentivized to have us in their practice. We generate significant revenue for them so that they want to continue using us. And as an anecdote to show that we're providing significant value to them and the patients, we've had at least 5 instances where when we were on the phone monitoring a patient, they were actively having an MI or a stroke. They were reporting active chest pain going into their arm, slurred speech, dizziness. In all 5 of those instances, we called 911 on the patient's behalf. 911 arrived to the patient's home. In 2 of those instances, the patient was found down on the floor, passed out. They got taken to the hospital, evaluated, treated, and they're significantly better. And in one of those 2, the reason that they passed out was because they live in Arizona. It was so hot and they didn't have an air conditioning. So we actually flagged the team to see if we could get them an air conditioner, and the practice actually bought them one for $100. So we're providing value. We make it easy. We have incentives aligned, and the patients love it. So that's how we get into practices.
Thanks, Leon. That was a great story.
Yeah, for sure.
All right, next up, AccurKardia. So we've already heard a little bit about ECG and how important it is. and interpretation. And there's so many different devices out there. So Juan, tell us about AccurKardia and how you're going to make a significant impact on patient care, and give us an example if you can.
Sure. Thank you, Paul. Just to start, AccurKardia FDA cleared products have CPT codes and have a reimbursement for home health and remote patient monitoring. But given that the topic of today's provider diagnostics, I am going to share a story how our technology can help provider care, particular primary care. I think we can spend a lot of time today to show the impact to patients, how earlier intervention, earlier diagnosis for AFib or aortic stenosis can save lives, can prevent stroke. But I like to also mention the benefits for our partners, which are the providers. I think it's our technology can integrate with the current clinical workflows. Second, there is no need for CapEx or investment on new equipment. And three, we can leverage the ECGs already stored in the provider healthcare system, either in the GMUs or the EHR system. So, for example, in the case of aortic stenosis, which is a disease highly complex to detect in the mild or moderate form, looking at 10,000 patient ECGs in any given practice can yield up to 200 patients of moderate and severe aortic stenosis. An early intervention to the patient population could help increase their lifetime, quality of life, and save lives in patient care. But as one of some of the colleagues and finalists here are providing, revenue generating is key for the healthcare system currently because they're strained on reimbursement rate reductions. So for each 10,000 ECGs that we can scan with our technology, we can find 200 cases of missed aortic stenosis, and giving them a solution that can give them 10x return of each dollar invested in the AccurKardia technology. So I believe that's key for healthcare system in particular areas when there is a lack of cardiology care.
Well, I like it when you say 10x returns for people. That's good. It's fantastic. Thanks, Juan. All right, one more to go. Take us home, Sushi at Bayesian Health.
I'll start with a simple example. So I said it's a multimodal clinical AI platform with multiple solutions on it. Sepsis as our leading beachhead product. A patient, when they come in with sepsis, let's say it's missed, the person ends up being hypotensive, they end up having multiple complications, they end up in the ICU. A hospital is getting paid a certain amount on a DRG. So if they end up being there for like 20 days versus a 5-day, that excess money is just out of their pocket. If they're using a lot of ICU days, that's just out of pocket. So the first level financially, the impact is from detecting this patient early, they can treat this patient in a timely fashion, save on secondary complications leading to ICU utilization, longer length of stay. So suddenly someone who's like a 20 per day or 10-day or 12-day or 15-day could end up becoming 6 days, 5 days. So a big savings on length of stay and the excess cost. So that's number one. The second is, if a patient comes as a present on admission, you're able to document them as present on admission. On many DRGs, that's a much more complex patient. So you're able to get 30, 40, 60, 70, 80 in some cases % higher reimbursement. And then the third is many of the conditions we tackle include, and many of the conditions we are tackling today have the same phenotype: length of stay, revenue from better documentation. And then the third is penalties. There are areas where, because these are critical areas, there's reporting to CMS around performance. And so as a result, there's awareness around penalties attached to it. And they're looking to, not be spending money or losing money because of those penalties. So that's on the financial side. On the clinical side, often health systems have like teams invested in this area, right? There are whole quality teams that are focused on improving these because they're high value, important areas to tackle. So one, it improves patient outcomes. It improves on key metrics like length of stay, mortality that many contracts are tied to on whether you're a fee-for-service system or a VPC system. And so, those clinical outcomes are obviously improving it, has also reputational benefit. The third, and very interestingly from a frontline workflow perspective, is they have a lot of tooling today that they hate. It's like alarms and alerts that create a lot of BPAs and noise. For instance, at Cleveland, as an example, we showed 10x reduction in alert volume, 10x. So they went from 10,000 alerts to 900 passive flags, but we were catching 40% more cases. So from a provider burnout perspective, we dramatically simplify the workflow. We're reducing, an existing tools they have that are clunky. And then from an IT perspective, because it's a platform where we're not just sort of putting one point solution, but like multiple multimodal clinical AI solution. Today, a lot of those are the ones we've built, but now, we have some news coming where basically other systems are now implementing and deploying that through us. What makes us something they want to partner with is our adoption, our provider adoption. The fact that we can drive provider adoption is where, people have struggled with AI solutions. And so our ability to reliably and consistently drive provider adoption is what gives them comfort that we can go after many, many areas together that are high value, high stakes.
Fantastic. All right, listen, you guys all did tremendous. Great group of companies, amazing solutions, and we're really excited about seeing all of you at the health conference coming up. So I'll give it back to our health hosts here to, our Digital Health Hub Foundation hosts to close this out.
Great. Thank you so much, Paul. Great job, and great job, everybody. It was so interesting hearing from all of you. I just want to send a reminder that we have 3 separate events on October 21st for the grand finale. I dropped the link in the chat, so please make sure that you go ahead and sign up so we can see all of you there and celebrate together. Thanks so much.